European countries that failed to replicate. So this is a big problem. I would argue that this is a problem across the spectrum of clinical neuroscience. So the way you design your study is obviously critical to your ability to then recruit your sample. And my first recommendation that I would make is to think about recruitment when you begin the process of designing your trial. It's never too soon to start thinking about recruitment and retention to your trial. If you are unable to recruit your sample, you are unable to answer your question. So if you take one thing from this talk, it's that. Don't design a trial that's not feasible. Don't design a trial that requires an intervention that is simply not something that people will be willing to do or able to do. And certainly consider the standpoint of the patients that you will try to accrue in your study when thinking about design elements. I'll talk more about that. So the feasibility of recruitment is tied very closely to the eligibility criteria that you will implement in your trial. This is from Paul Lieber, formerly of the FDA. It's a nice paper talking about eligibility criteria. Obviously, you want to include patients who certainly suffer from the disease of interest. In order for your trial to succeed, you want to enroll patients who are most likely to benefit from that therapy. But you also want to enroll patients who will give you data that's generalizable to others who suffer from this disease. This becomes a bit of a competing interest that you have to consider when designing your trial. Ensuring that if your therapy is effective, you are able to show it versus the generalizability of your data will be a balance that can be difficult to strike. You also want to think about, are you going to be able to keep these patients in your trial so that you can answer your final data point or change from baseline, whatever that design may be. How you design your trial eligibility criteria can actually impact your ability to show a treatment effect. These are data from multiple sclerosis, looking again at a chronological effect over the course of trials, where you can see that the enrollment criteria from some older trials require that patients have 2 relapses in the previous 2 years. Now it sounds mathematically equivalent to then in a more modern trial use 1 relapse over 1 year, but what you can see is that within these trial populations the relapse rate was different, and as such the power to show a change in that relapse rate was different. So how you define the diagnostic criteria for participating in your study can also impact your ability to show a treatment effect. Similarly, in stroke trials, the most common predictor of accrual rates is the required time from stroke. So a greater window of time predicts a greater recruitment rate. But obviously, if you adhere to time is brain, you're going to really think about choosing that time point very carefully. Last year I was part of an NIH work group that really urged investigators to think about inclusion criteria from a number of standpoints, focusing on the fact that for a lot of areas of medicine, not just clinical neuroscience, the bulk of patients represented in a disease category are severely underrepresented in our trials. And there were 2 real primary take-homes, one listed here at the bottom, that we want to change the culture of medical research from one of protection from research to one of protection through research. It's a nice moniker. The other one is even easier to remember, and it's that age is just a number. And you know, even in Alzheimer's disease, clearly an age-related condition, I was struck as I prepared for this meeting to go back into our trials to find that we unnecessarily apply a maximum age cutoff in the majority of our trials. That's often 80 or 85, but 80% of Alzheimer's patients are 75 and older. So are we actually misrepresenting the population when we do our trials? And I would certainly recommend that you think about choosing age cutoffs as well as every other cutoff very carefully. And you know, I can show you patients in our trials who you would mistake the 65-year-old for the 85-year-old in many cases. So can biology and clinical outcomes be used rather than age, for example? So I mentioned that I would urge you to think about the patient perspective when designing your trial and thinking about trying to recruit it. Here I'm putting 3 papers that looked at barriers to participation in Parkinson's disease, hypertension, and some of our work in Alzheimer's prevention. Don't worry about the individual bullets, because I'm going to summarize that the lists here and the frequency with which people said they choose to participate in clinical trials can be distilled to really 3 primary reasons. They trust the investigator or the institution where the study is being performed. They are altruistic and they want to help mankind, and they want to benefit. They want to have access to a therapy that they otherwise cannot gain access to, or access to experts. Another term in the literature that I really like to describe the reasons that people choose to participate in trials is conditional altruism. Yes, I want to help, but I really do hope I get something out of it as well. And there's also literature on therapeutic misconception, but I think hope is important. I think the desire to benefit is critical, and that we should think about this when we're designing our studies. In contrast, same 3 studies here that I showed you before, the reasons why people choose not to participate in research, I would argue, are highly specific to the patient population. Why someone says no to an AD dementia trial is going to be very different from why someone says no to a headache trial. And so herein, I think, understanding why people are going to refuse to participate in your trial is an important exercise that every trialist should engage in when they think about designing their study, and then attempt to minimize how the protocol is going to affect people's desires to participate or not. Another important point is to think about who is the decision maker in deciding whether to participate in your trial. This is data from my mentor, Jason Karlowicz at Penn. I think it's a beautiful illustration of, over the course of a disease, how decision making can change. So this is the mini-mental state on the x-axis. 30 is a perfect score. So these are all in patients who have AD dementia and their family members or caregivers. And what you can see is that even when a person's cognition is largely intact, the most mild stage of Alzheimer's disease, only about 50% of the time are they making autonomous decisions. But over the course of the disease, who makes the decision, in this case medical decisions, but similar research has been done with trial decisions, that's going to evolve and shift away from the patient themselves and more to the caregiver. And we've shown, for example, that who participates in AD trials is really not very representative of the larger national population of people with AD, in part because certain caregivers are substantially underrepresented because they're less likely to participate in trials. So you really want to have a very intimate understanding of what the patient dynamic is and whether they're going to be able to choose to enroll in your study. So for all of us, we can do our best to minimize barriers. We can think about opportunities to try to make it a lower burden to be in our trial. We may think about remote data capture through telemedicine. Now there are increasing numbers of smartphone apps and the like, so that we can try to collect data without requiring people to come to our ivory tower academic medical centers, which for especially rare diseases may be extremely difficult considering our catchments. Doing this may have other implications. For one of the NeuroNext studies, for example, the FDA cautioned against overusing telephone safety visits for the integrity of the data and the potential for regulatory review later on. Again, some data from my colleague Jason Karlowicz using really a business marketing technique, something called a conjoint study, to try to understand the utility of specific design elements and their impact on making people more or less likely to participate, in this case AD caregivers. And what you can see is that offering home visits, offering car services, these things can increase the willingness of caregivers to enroll in trials by minimizing the burden on them. The positive control in this study is to show that a trial that has higher risk reduces caregiver willingness to enroll their loved one in the study. And now I'm going to take a couple minutes just to talk about this last bar on the furthest right, which is something called alternate allocation. In this study, caregivers of people with dementia said they'd be more likely to participate in a trial if their loved one with the disease was more likely to get actual therapy compared to placebo. So compared to a trial that had a 1-to-1 randomization, one with a 2-to-1 randomization increased caregiver willingness to enroll with the participant. So this is something you may think about. Well, I'm really worried about getting people into my trial, so I'm going to have a 2-to-1 or a 3-to-1 randomization scheme so that people are more likely to get active drug than they are to get placebo. There's a lot of benefits to you using this. As I showed you, it may increase willingness. It may be that you want to test multiple drugs, and so you're going to have 3 equal randomization arms, 2 different doses of drug versus placebo. More people are going to be exposed to the therapy under investigation, so you're going to get more data and better information about adverse events. The converse to this is something that should be considered carefully. It may require a longer trial. It will certainly require a greater sample size, and there are considerations of cost that should be made. And Steve Edlin and his colleagues at UCSD did a really very nice theoretical study where they looked at just how much faster recruitment would have to go to justify these different alternate allocation rates. And those tables on the left and the figure in the middle are from that paper that I would recommend. But it showed that if you were going to do a 2-to-1 alternate allocation so that someone's twice as likely to get active medication compared to placebo, that the trial would have to recruit 12% faster for the total time to conduct the trial to actually be beneficial. And it would have to recruit 47% faster to actually be a cost savings overall for the trial. And my personal opinion about this particular strategy is that it is rarely effective at actually increasing overall recruitment for a trial, because I find very few people who are willing to be in a trial, who are unwilling to be in a trial, will change their mind if there's a greater chance of getting drug to placebo. I think that really the hard thing about this is to measure these differences. You have to take someone who would otherwise say no to a trial and convert them into a person who enrolls to actually change the overall recruitment for a study. And I think that that's actually an infrequent occurrence with design elements such as alternate allocation. Other implications to your design should be considered when you're using alternate allocation. This is a really amazing study. It's a meta-analysis of dopamine agonists from Parkinson's disease trials. What I'm showing you here, straight from the paper, are people who were randomly assigned to receive active medication in dopamine agonist trials. In the blue bar are people who were in trials with a placebo arm, but they got active medication. And in the red bar, people who were in an active control study, but got the same category of medication, dopamine agonists. And what you can see is that those who were in an active controlled study compared to a placebo controlled study had a greater response on the UPDRS. So why do we have placebo response? We're conditioned to go to the physician and get better. And we have expectations. And in this case, expectations, specifically the expectation that I'm going to get an active therapy that's supposed to help me, had a significant, statistically significant with a whopping sample size, a statistically significant impact on an outcome that's used as a primary outcome in trials. So this design feature can actually, and the title of this paper was the placebo effect, because it becomes more difficult to show a difference from control when you increase the expectation that someone is going to receive active therapy, or receive a therapy that will Other design choices that you should consider. In our trials, especially in prodromal Alzheimer's disease, we now have as high as 80% screen failure rates. So what features of your inclusion-exclusion criteria are you going to permit rescreening? And clearly define this in your protocol. Under what circumstances can someone be rescreened? And I show some data here from an MS trial where greater than 90% of participants who were rescreened ultimately were deemed eligible and enrolled in the study, and that could be a major boost to enrollment. Similarly, these are data from the esteemed Dr. Moyer here at University of Michigan in a status epilepticus trial, if I remember correctly. Very thoughtful design. Only first enrollment was used in primary outcome analysis, but here you see that each row of data in this figure is an individual who was enrolled in the trial multiple times. And there were people who were enrolled 2 times to as many as 14 unique enrollments for a given individual in this pre-hospital admission interventional study. So really considering how frequently someone might be enrolled in the acute setting especially. Turning now to other ways we might try to improve recruitment. This paper just came out a couple of months ago in the New England Journal of Medicine by Galinas and colleagues. And it outlines from an ethical standpoint whether paying people to participate in studies is ethical. I would argue that before I get to paying people, rarely if ever is it ethically appropriate for people to pay to participate in clinical trials. I recently had to write a letter to the editor of our local paper about that topic. I'm happy to talk about that another time. And alternatively, I think it is very ethical, if that's a term, certainly ethical to pay people to participate in studies. This paper outlines 3 categories of financial incentives. Reimbursement, I think we should all strive for patients to not incur cost to participate in our studies. Compensation, paying someone a fair wage for the amount of time and effort they put into enrolling in our studies. And incentivization, paying greater than a fair wage to participate in studies. And again, undue influence is outlined in the Belmont report as an inappropriate reward in order to induce compliance. And I think that we can certainly offer incentives, financial or otherwise, without being unethical, without offering an undue influence to make it easier for people to say yes to participating in our clinical trials. There have been a number of studies that have tried to empirically examine the ethics of paying people to participate in research. Again, some data from Scott Halpern showing that although willingness goes up with increased financial incentive, risk tolerance is not on an interaction effect, so that people remain adverse to greater risk even when payment goes up. He also did a really fascinating study with survey studies of the American Medical Association membership, and showing that although a $10 incentive increases the total number of responses, that the cost effectiveness was greater for a $5 incentive. So again, choosing wisely is important. And then some of our own data suggests that while financial incentives may increase willingness to participate, participants, in this case potential participants in an Alzheimer's prevention trial, have greater value in other forms of incentive. When in our study, this included getting personalized cognitive test results back, personalized genetic test results back, and even just getting top-line results of the overall clinical trial was of greater value to potential participants than were financial incentives. For most of you and most of us, the overwhelming majority of participants in trials come from the investigator's own practice. It's often difficult to get practitioners to refer participants to a trial, although there are novel ways that we'll discuss to try to better do this. But it's incumbent upon you to try to increase awareness of your trial as much as possible, so that you can diversify the participant population beyond your own practices. There are a number of ways to do this. You can certainly try to keep your colleagues aware of your study. For many of our therapeutic areas, there are disease advocacy organizations, many of which now have unique programs to try to match patients to ongoing clinical trials. Talk a little bit about brochures and the internet, advertising and paid and non-paid media. And we've spent a lot of time now in Alzheimer's disease, and it's true for other neurological conditions as well, with the advent of a novel tool in the form of patient registries and potential participant registries. So patient registries are not new, but the idea of enrolling people in a specific protocol that says they are willing to be contacted about clinical trials to some extent is. So most of you are at places that now have electronic medical records, and the opportunities to try to improve recruitment through medical records is something that you should certainly consider. Again, Will, you were part of this study. This was a flagging system where a person that was enrolled in the hospital system with an ankle sprain or injury was caused an alert to an NP or a study coordinator to say that a person was enrolled in the medical system who was potentially eligible for a study. This paper did a nice job of showing that the recruitment rate prior to the initiation of that flagging system was substantially lower than after it was started, and a very effective modality. I could not do this at my institution. We can't institute a flagging system where investigators are notified about patients being admitted or seen clinically who meet criteria for a trial. And I think that the use of the EMR is going to vary substantially from location to location, from institution to institution. However, most places are now putting into practice opportunities to use the EMR for cohort discovery and recruitment. And there are ways that you should pursue that can be done in an anonymized manner. Patients could be identified and sent a letter letting them know that they may be eligible for a trial, and then self-present to the investigator or the program conducting that trial. Or in some cases, you can actually get a list of patients who meet specific clinical criteria and IRB approval to then contact them in some manner and invite them to learn more about the study. We've been looking at this to some extent from a research standpoint, and I will tell you it's been low yield for us. We got permission to identify patients seen over a 1-year period at our institution with a diagnosis of mild cognitive impairment, and we sent them all a letter and then began trying to call them all. It was extremely low yield, and now we're moving toward a model where we, in bulk, invite patients seen with a particular diagnosis to community educational events to talk about research and talk about clinical trials to see if that's a more effective way to get people into our studies. Point is, this is an incredible resource that's still relatively new and may, in fact, be an excellent way to increase recruitment to your study. Similarly, we now live in the age of Facebook and Instagram and Twitter and other social media opportunities to try to, if nothing more, increase getting the word out about our studies. And even better would be your trial goes viral in particular chat rooms or support groups that are run electronically through social media. I cite here a paper, again, by Galinas and colleagues that tried to outline the ethical issues around doing this. It's very appropriate and pertinent although some of the things kind of came as a surprise to me. So each of these points is outlined in the paper, but I'll just make note that in case you were thinking about it, you should not pretend to be a patient in order to gain access into a patient chat room, and then miscommunicate or deceive members of that chat room in order to get them into your trial. There you go. This is one of my scientific heroes. This is Ray Dorsey from the University of Rochester. Ray now has a clinical research study being done through the iPhone on an app that has enrolled 10,000 participants into a single study. More than 90% of those individuals said they had never participated in research before this. They're doing a finger tap task on their iPhone to collect data about Parkinson's disease. Most of them don't have Parkinson's disease, but enough of them do for it to be a very robust sample. And this app through the iPhone really is a great example of using technology to boost enrollment into research studies. I would recommend you go check out apple.com/researchkit to learn more about the numerous types of therapeutic areas that are now using this. These include apps to improve health as well as to enhance research. And just last night I went and looked, and there's now an app and connecting to the Apple Watch to potentially do a study and change clinical practice around epilepsy and seizure onset. So clearly relevant to our interests. So technology is great, but old school paper brochures are not without a place as well. Brochures can have a lot of effectiveness and can be used in a number of ways. It may be that you want to invite all of the participants in your trial to take a brochure and invite someone else to be in the study. And it gives them a tool to talk about it, to hand them, to hand other patients that they know something that can let them then contact the site and consider participating. I think you'll get the slide, so I won't belabor this. Some general rules of thumb about brochures: don't use 11 or 12-point font. Don't use single spacing. Make this aesthetically appealing. Make it colorful. Make it big. Make it bold, and make it answer the most obvious questions that a person who might be willing for your trial would have. What's in it for me? Why should I do this? Don't overdo it on details of your protocol. This is not clinicaltrials.gov. This is an opening to a conversation. Notice the super baby flew in there. This is a really nice brochure from a NeuroNext trial for an SMA study. But again, it's really meant to be a conversation starter more so than it is an answer to every possible question about trial design. Brochures don't have to be paper. For the NeuroNext myasthenia gravis trial, there were a couple of different things that were done online. And I don't have the videos to show you, but I really love this modality. There was an educational video created on myasthenia gravis, and then a second one about the actual NeuroNext trial. And so I don't know if you remember those UPS commercials where it was like a postal service song and a guy standing at a whiteboard with a brown marker, a dry erase marker, and he would sort of create all the illustrations. So this video does that. You watch a very aesthetically pleasing hand with a Sharpie sort of create all the diagrams and illustrations for describing the trial. And I found it to be very effective. Obviously, multimedia creates new opportunities for brochures that we should really pursue. And actually, we should also think about writing into trial budgets for the grants. Budgeting for recruitment is something I'm happy to talk about people, but certainly something we should do. The other thing that we've had good success with in our program is not paid advertising. That actually has not worked well for us at all. On the other side, earned media. This is getting a local reporter to do a study about your trial has been very effective in garnering participants for us in several different studies. This is Paula Hunter. She was, when I moved to UC Irvine, she was the only person enrolled in the anti-amyloid treatment in asymptomatic Alzheimer's disease study, or A4 study, the first ever preclinical Alzheimer's disease trials in people with normal memories but a head full of amyloid. And she agreed to tell her story to a newspaper, and up on the front page, and we got 80 calls by viable candidates in the following 10 days, and was a major boost to enrollment in this study at our site. And again, I find this, we've actually published a couple of papers about earned media being perhaps the most effective recruitment strategy, although it's not one that everyone can simply implement because you have to get interest from a local paper or other media outlet. And I can tell you right now that you are much more likely to get that interest if you involve a patient and their story. If it's just about you and your brilliance, while I'm sure you're brilliant, it does not get the attention of the reporters to the extent that telling a human interest story does. Again, we have been using earned media to get people into not just trials, but also into our registry. We had a front page article in the same paper for our potential participants registry. These registries are potentially effective tools. We've begun showing this. There's very little data to support their effectiveness, let alone their cost effectiveness. And in Alzheimer's disease, for example, some of these registries are in the cost of millions of dollars. So I think there's a real need for rigorous study of the utility of these tools. Nevertheless, they are increasingly common and something that you should look into. If patient registries or other potential participant registries exist to which you could request viable candidates for your trial, there's often no risk for you, the investigator, in doing that. And trial recruitment should be about getting people who are right for your trial from any possible source. Okay, a few minutes on diverse participation. So in a number of disease categories, we suffer from a variety of sample biases. In Alzheimer's disease, we have biases based on the dyad type, we have biases based on education, and I won't show you data, but we have striking biases when it comes to racial and ethnic representation of national estimates of disease prevalence. This is important for us all to consider for a number of reasons. There's the ethics of the social justice of this. In this country, healthcare disparities are very prevalent, very challenging, very important, and to some extent are perpetuated by low diversity rates in our clinical trials as a whole. There's also a scientific rationale for increasing the diversity of participants in our trials. Race is a cultural construct with correlations of genetic underpinnings between self-reported race and ethnicity. And in a paper that I think I put in the reading list for this course by O et al. In one of the PLOS journals, they did a very nice table that outlines some of the observations of how race and ethnicity can affect disease prevalence for certain, but also efficacy and safety of therapies. So understanding this and using it to instruct the best clinical care possible for all people really boils down to data from clinical trials. And so to the extent that our trials lack particular segments of our population, we often enter into a clinical practice that has no appropriate instruction for practitioners as to how treatments are going to vary or maybe have different safety profiles in particular segments of the populace. And you know, there's this is from a, I think, 10-year history of NINDS funded trials, looking at effects over time, and you can see that we went from utterly abysmal to just terrible in the representation of Latinos and African Americans in trials. The data are actually worse than this in Alzheimer's disease specifically. NIH-supported trials have about 10% non-Caucasian participation rates, and in industry-supported trials, that number goes down to 3%. And that's in a condition where Latinos are 1.5 times the risk for Alzheimer's disease, and African Americans are double the risk for Alzheimer's disease relative to Caucasians. So a clear need. This is some data that we produced a couple of years ago, showing that African Americans are less likely to be willing to participate in an AD prevention trial. I show it to you because it's a direct contrast to a paper by someone I respect greatly, David Wendler, that suggested that African Americans are as likely to choose to enroll in a study when presented with one. I don't believe this to be true. I don't think it's as simple as we just need to make different races and ethnicities aware of our trials and then they'll agree at the same frequency. I think it takes much more work than that. And in fact, in our study, we looked at potential barriers, and we found that African Americans compared to Caucasians had a heightened sensitivity to the importance of a variety of trial design elements in the process of choosing whether to enroll in that study. This should come as no surprise. The literature and our history as a field of clinical research is littered with atrocities that have produced inherent skepticism among underserved racial groups about medicine in general and clinical research in extreme. And it's incumbent upon us to put in a major effort if we're ever going to get past some of those things. So I don't think it's as simple as making sure people of different races and ethnicities are aware of your study and hoping that they'll say yes. And actually moving the needle on this topic is going to take major investments by institutions as a whole, and you may be able to play a role in that. So I work at a NIA-funded Alzheimer's Disease Research Center. We have specific cores that are devoted to outreach and recruitment, and we have had to put a lot of effort into trying to make inroads into getting diverse people into our research. And I think things that are listed in the slide, including having a long-standing presence in the community, partnering with advocacy organizations and leadership from the community you hope to recruit, creating a network of practitioners who are seeing these patients that may not make it into your academic medical center, and doing everything you can in your trial to reduce logistical barriers to participation by these groups, all are essential. More practically, when you're thinking about writing your grant or designing your protocol, what should the goal be for recruitment? In a phase 2 trial, it's unlikely that you're going to be able to look at the specific efficacy of your treatment in racial subgroups. In phase 2 trial, you're probably not even going to be able to look at efficacy in the whole sample. So how then should you make decisions about targeted recruitment and diverse enrollment? It's going to be very specific to your protocol, but striving for an adequate representation of specific groups is certainly going to be important. There are different approaches that people take to this decision. It could be to create a 1-to-1 ratio between your trial sample and the national prevalence by race and ethnicity of your disease. It may be that you choose to use a more local geography to instruct your recruitment goals. My colleagues at the Mayo Clinic in Rochester have great difficulty recruiting African Americans to trials at their site. So again, I think it's going to be specific to your protocol and location, but I think that a thoughtful approach is necessary. The O article does a really nice job of also outlining issues around budget. It's not easy to do this, and it requires resources. And investigators are understandably hesitant to create very large grant budgets that adequately account for the costs of doing diverse recruitment. And so I think there's a need, and again, I refer you to that article, to try to change the culture of NIH grant review and grant writing if we're going to make a difference in this particular area. Okay. So last slide on recruitment then. What do you do if you have your trial, your protocol's launched, and recruitment looks like the beginning slide? You're just not achieving that one subject per site per month, or you're falling short of your goals. There are some steps that you can take. Analyzing your data to some extent, not unblinding yourself by any means, but looking at why your trial is going slow could be critical to instructing improvements. Is it that recruitment is actually not the problem, but that no one is actually qualifying for your study? Is there a shortage of people who don't take particular medications that you've excluded? And can you consider adjusting your criteria to get those people into the study without sacrificing the validity of your results? If the trial is recruiting slowly, but certain sites are really knocking it out of the park, can you learn from what they're doing and share that information with other sites to try to improve recruitment practices? Are there things that I talked about in this talk that you had not yet considered? Are there patient advocacy groups that aren't aware of your study? Are there registries you can tap into? Have you not looked into the medical record? All of these things should be considered. Okay, I'm probably out of time. I only have 180 slides left. So to turn to retention briefly, it's important to say that accruing a full sample to your trial and having half of them drop out is as bad as only accruing half of your study. In fact, when I consent subjects, I often tell them that we're better off if someone chooses not to enroll in a trial than if they choose to enroll and drop out. To be clear, I think retention is as important as is recruitment. This is from a review we wrote a few years ago looking at retention rates for Alzheimer's disease trials. Again, I've color-coded it based on an industry standard of 80% power calculations that are based on 80% completion. And so you can see that more than half of studies that we looked at failed to achieve 80% completion rates in their trials, potentially reducing power or leaving the trial underpowered. I heard there was a great talk last night that defined a failed drug versus a failed trial. The studies in red, pink, and yellow are at risk of being failed trials and not actually answering a question about whether a drug helps the patient population. Last observation carried forward is not a commonly prescribed data analysis method, but this is a really nice illustration that if you're trying to show a disease-modifying effect and you use last observation carried forward and your drug actually causes dropout because of side effects, you could actually misinterpret the data to think that a drug that simply causes side effects is actually slowing the course of the disease, in a disease that has a natural history progression associated with it. So dropout can actually impact your ability to answer your question not only just by power, but it can result in error. And I would advise that you try to, again, understand your patient population. So these are data we published from a review of several Alzheimer's disease clinical trials where we showed that the type of diet that was enrolled in a trial was significantly associated with the risk for dropout. And so it may be that there are particular patients enrolled in your study who are most likely to fail to complete that study. And that may require education of your investigators or your single site team to say that we really need to hold the hands of these particular participants to make sure that they finish the study. Again, this is from a meta-analysis by some investigators at Hopkins They've done 2 iterations of this meta-analysis, identifying first more than 200 and now more than 900 different retention tactics, and they've categorized those tactics into 12 strategies that are listed here. I won't belabor them with you. I'll simply point to the paper and show you that in their data, again, taken from IRBs when possible, the more retention tactics that are used, the better the retention rate. And we've actually recently completed a survey of the Alzheimer's disease research centers, 30 NIA-funded centers, and we have a very similar plot, maybe even a little nicer plot than this one, with NIH congressionally mandated centers of excellence, showing that the more effort that goes into retention, the better the overall retention rate. So the gist is, think about this. Think about how you're going to plan this in your protocol. What steps are you going to take to minimize dropout in your trial? My summary recommendations for retention: minimize burden on the participants, make it as easy for them to not only enroll in the study, but to finish the study as possible. Share best practices among the sites if you're doing a multi-site trial. I really believe in the importance of sharing information with participants. What I tell people at our site is, when you enroll in a trial, you're no longer a patient, you're now the most important member of a research team. And so I think giving them information as if they are an investigator is one strategy to retaining them. That doesn't mean giving them information about, how many AEs have happened in your trial so far. It could be just telling them, how close are you to completing accrual? How long is it until we actually know the answer to our question? Can you do a newsletter from the PI? How can you make them feel engaged in the study so that they don't simply feel like they're just one more patient in a very large study? Find as many ways as possible, show gratitude to them. I'll show you a great one in a couple of minutes. Again, financial incentives may make sense, and other forms of communication. Old-fashioned thank you notes, handwritten are best. But show them that you appreciate the contribution they're making to what you want to do. We annually have a thank you event at our center, and one of the fun things we do right before that is decide what tchotchke we're going to give everybody that year. We're kind of running out of cheap buy in bulk, parasols and travel mugs and fans and many things. Again, think about social media. Is there an opportunity to stay in touch with people at a level never before possible? And then, when I was a site PI at UCLA, and I don't get to do this as much as I used to, but I made a point as PI to try to see every participant at every visit, even though I wrote myself out of the protocol as much as possible when it came to standardized data collection. And I would just go and thank them for being there. And I know that it made a world of difference, and I have anecdotes, not data, that a couple of folks who were really going to drop out didn't, because of that level of thought that we put into it. This is data we published last year about sharing top-line results. And this is data from Erica Augustine, who I'm sad isn't here, but she's a Neuronext investigator. And this is about the manner in which data are communicated to participants. In the first paper, this is about top-line results. We showed that participants and caregivers in a phase 3 mild AD trial, if they were unsatisfied with the manner in which they received top-line results, it was exclusively among folks who learned by the media. And every participant in this very small study said that their preferred method of learning top-line results from a trial was through the site. There was one exception. He's a bit of a curmudgeon. He expected an email from the pharma company, but I think he's an outlier. Erica's paper was about change in protocol and doing a webinar, an anonymous webinar, where everyone in the trial was invited to log into a webinar for the overall protocol PI to talk about the change in protocol and why it was necessitated and what it meant to participation. So again, I think there's real opportunities to change the way we do things and to use less of a top-down approach and really make participants feel more engaged and more members of the larger research team. And I believe that can absolutely have an impact on our overall retention rates. This is the last slide, really. This is the onesie that was given to all the participants in the NeuroNext 101 trial in spinal muscular atrophy. And Lori promised at karaoke she's going to wear a cape. But again, I think that the point is that this was planned. In advance. These things were donated, if I remember correctly, by a company who the trial was led by investigators from the Ohio State University, and it's an amazing demonstration of thoughtfulness and gratitude. The SMA trial. I don't need to explain the heartache of families dealing with SMA, but the trial actually also enrolled healthy babies that had to have sticks and visits, and not an easy thing for parents of an infant to do. So I think that that challenge was recognized up front by seasoned, thoughtful investigators, and they took a number of steps beyond this one to try to plan a successful trial in recruitment and retention. And this was one key component of that. So I think I'm over time. I'll just summarize to say that recruitment and retention are important. Planning should begin early, and to the extent that you're able, I would talk to patients, I would talk to advocates, and I would incorporate what you hear from them in your design as much as possible. So I will stop there.